Welcome everybody. Today we are going to talk about the acid-base disorder. This is not an easy subject, and especially we are going to introduce you the combined acid-base disorders. So let's start it. The normal pH is very important in our body. So the hydrogen ion concentration is very closely regulated. If you compare the concentration of the hydrogen to the other ion that we do have in extracellular spaces, such as the potassium and the sodium, you can see that there are about 100,000 or 1 million times more that comparing to the proton concentration. The normal proton concentration in our body is ranging between 36 to 44 nanomole per liter, not millimole, but nanomole per liter of the hydrogen ion concentration. Now, we do have a relatively very narrow band. Now, the pH, as you know, this is a negative logarithm of the proton concentration, of the hydrogen ion concentration. So that's a strange number. However, we are still using it. Today's in the laboratory data, it's expressed in the nanomole as well, not only in the pH. Now, the pH, the normal range for the pH is ranging for 7.35 to 7.45. Now, if you do have a higher concentration of the uh, hydrogen, that more than, for example, 44 nanomole per liter, we are talking about acidemia. So acidemia means that the pH is less than 735. Alkalemia means when the hydrogen ion concentration is less than 36 nanomole per liter, and we are talking about a concentration. This is why we say alkalemia. Now, if the patient is out of the range, for example, less than 6.8 or more than 8, that is going to die. So this is why it's important to control the hydrogen ion concentration. Now, what's going to influence the hydrogen ion concentration in our body? Relatively, we do have a production rate. This production rate is based on the metabolic function. All cells is going to use up, for example, burning the carbon and producing carbon dioxide. This is the most common end product of in our life. This is called volatile acid because we can exhale it. Another one that we cannot burn into the carbon dioxide and we cannot exhale, this is what is called is a non-volatile acid. That's, for example, the lipids and protein breakdown and product that cannot excrete it from our body, and that is produces about 1 milliequivalent of 1 millimole per body weight kilogram in every day. Another important one, not only the production, but the elimination of the produced acidic product. Now, what kind of organs is taking place in this extraction? The lung, for example, the kidney, the liver, and these organs attempt to maintain the hydrogen ion balance. Now, the acid-base balance, or the concept of the acid-base balance, is more than 100 years old. At the first, Henderson and Hasselbalch describe how could we evaluate and what kind of parameters is mainly affecting the pH of our body or the hydrogen ion concentration of the body. As you see here, there are two components we do have. One component is the base, such as the bicarbonate, and another component, the acidic one, is the carbon dioxide, because mostly what we do have about 15 mole carbon dioxide that produced every day. So this is a major component of the acidity. And another component of the bicarbonate that's around 24 millimole per liter. Now, the Kd, or this Ka, this is a dissociation constant that relatively is, which is a half of the compound that is ionized in this pH. Now, if you are looking at why the bicarbonate system or bicarbonate and carbon dioxide system is very important in our case to control the hydrogen ion concentration, let's see what's going to happen. In the systemic circulation, the hemoglobin is oxygenized and this arterial blood goes to the peripheral tissue. What's going to happen in the peripheral tissue? In the peripheral tissue, the oxygen is going to diffuse into the tissues and the carbon dioxide is diffusing everywhere and including the red blood cells as well. Now, in this way, the tissues are oxygenized very well, and the carbon dioxide that is relatively in the plasma or in the red blood cells, but as you do see in this picture, mainly is accumulating inside the red blood cell. But why? Because when we do have this situation, the carbon dioxide that is entering into everywhere, but especially into the red blood cell as well, we do have something, an enzyme in the red blood cells that is going to accumulate the carbon dioxide into the red blood cells. And this is the carbonic anhydrase. Now, carbonic anhydrase is going to produce the proton and bicarbonate. Now, bicarbonate concentration increases in the red blood cells, and we do have a drive that growing the bicarbonate out from the cells and chloride is exchanged. So the chloride is going to accumulate inside the red blood cells. Why? The bicarbonate is in the plasma. Now why this hydrogen is very important? Because this hydrogen is going to buffer the hemoglobin, because the hemoglobin, when the oxygen is dissociated off from the hemoglobin, that's be very, very alkalic, and this is buffered by the hydrogen. If not, that's be very toxic. So as you see here, relatively in the periphery, the red blood cell is going to carry the hydrogen of the CO2 and the bicarbonate carried by the plasma. What will happen? Now we are going to the pulmonary circulation. We do have a hydrogenized or reduced hemoglobin and chloride inside the red blood cells. And what will happen in the alveoli? Now we do have the oxygen is coming in, replacing the hydrogen. The hydrogen is going to relatively associates with the bicarbonate and chloride goes out. And this bicarbonate plus the hydrogen makes the carbonic acid. The carbonic acid is going to dissociate very fast into water and carbon dioxide. Now, carbon dioxide is going to diffuse out because in alveoli, the partial pressure of the carbon dioxide is almost zero. So it's going to diffuse into the alveoli. And of course, we are going to remove by respiration the carbon dioxide level. So we do have a drive that is sucking the carbon dioxide out of the red blood cells. And the oxygen goes into the red blood cells. So this is why it's very, very important in our case to consider the bicarbonate and the CO2 level, because this is the mainly component or mainly metabolite that we are going to produce by every day. Now, what kind of organs are, let's say, taking place in this production and excretion? A lung relatively its action is immediately and can regulate the partial pressure of the carbon dioxide. If you exhale more, the PCO2 level decreases. If you exhale less or the respiratory doesn't work perfectly, the PCO2 level is going to increase. Another one is the kidney. The kidney is capable to lose or produce bicarbonate. In the proximal tubules that can, for example, reclaim or reabsorb the filtered bicarbonate, about 85% of the filtered bicarbonate, while the distal tubule can reclaim the left 15%. And in the distal tubules, we can excrete the hydrogen. So this way the kidney is going to alter or going to regulate the acid-base balance very nicely by producing or excreting hydrogen or making bicarbonate or regulating the bicarbonate production and excretion. The liver is another very important organ. First of all, it's going to prevent the accumulation of the ammonium. And uh, and another thing, liver can produce, for example, CO2 as well, mostly from the complete oxidation of the substances. Or it can metabolize the organic acids, such as, for example, lactate, ketone bodies, or amino acids. And as we said, the metabolism of the ammonium again is uses, for example, bicarbonate to make urea. And very importantly, the liver is going to produce proteins such as the albumin. And albumin does have a buffering capacity because they do have negative and positive charges, and this is how it can regulate the proton concentration. We are not going to think about the bone, but bone taking place an important role, especially in the chronic situation when we do have a long-standing acidemia because the proton can be absorbed by the bone in the surface. We do have a loosely bound calcium, and that hydrogen is going to replace the calcium and potassium and sodium out of the bone, and in a long-standing acidic production or acidemia can cause osteoporosis. So this is why it's important, especially in girls, they should not drink regularly gassed beverages because if you drink, for example, the soda carbon dioxide that always produces a little acidemia, and that can increase the absorption of the hydrogen. As you can think about the Coke as well. Now, let's see the buffer system of the body. We do have the chemical buffer system that usually this is the first line of the defense mechanism that is going to absorb or release hydrogen depending what they need. Now, this kind of buffer system is composed mainly by carbonate buffer system, phosphate buffer system, and the protein buffer system. Another second line that works right away, that is a physiological buffer system, mainly the respiratory mechanism that can increase or decrease the rate of the respiration. That can work right away. However, the renal mechanism, the kidney mechanism that regulates the bicarbonate excretion and the proton excretion, it's going to turn on a little bit slower. It takes about 2 to 3 days when it's fully active. Now, let's see how this bicarbonate buffer system works. Now, we do have, as you see here, this is the bicarbonate buffering system. That's a normal situation that, as you see here, that can be filled up with carbon dioxide and water. And then other one, this is a bicarbonate reserve capacity when we do have, let's say, the sodium bicarbonate system. Now, in this case, when a hydrogen ion is increases, relatively, we are going to decrease the hydrogen ion concentration by making more carbon dioxide. Or if we do have a decrease, that we can have, let's say, a relatively increase of the bicarbonate ion concentration. Now, if we do have, as you see here, the fixed acid that you given to the system, what will happen? Increases the carbonic acid concentration that dissociates to carbon dioxide and water, and of course the carbon dioxide removed by the lung, and is going to refill, let's see, are you going to use up the bicarbonate, and the bicarbonate is going to coming out from the bicarbonate reserves stores. So this way the bicarbonate is going to be less. That is normal. In the normal situation, the ratio of the bicarbonate and the carbonic acid is about 20 to 1, the ratio. It can be altered if we change bicarbonate or the pH. The other buffer capacity, that other buffer system that we do have, the phosphate buffer, but majorly this is located intracellularly or in the urine. As you see here, we do have the biphosphate or the monophosphate, and relatively, for example, that biphosphate can absorb, for example, the hydrogen, and other one usually the hydroxyl ion, and this buffering capacity that is going to alter or maintain the normal hydrogen ion concentration. The protein buffers, the most, let's see, the important buffering capacity that we do have the hemoglobin. Relatively, the hemoglobin has a very high uh, capacity to buffer the hydrogen. And the carboxyl groups gives up, let's say, the proton, while the amino groups usually accepts the proton. Now, in the side chain that can buffer the hydrogen is usually present on about 27 amino acids. So this is what is making, let's say, the buffering capacity. Now, what's happening in the respiratory compensation of the acids? As we mentioned, if we add hydrogen to this bicarbonate and carbonic acid buffer system, what will happen? Now we do have more and more carbonic acid, and this carbonic acid, when it dissociated to the water and the carbon dioxide, and the lung is going to remove the PCO. So this is by using a bicarbonate, we can buffer or we can normalize the hydrogen ion concentration, and meanwhile we have more and more carbon dioxide that exhaled. Now later on, what will happen? The other buffer system that is binding immediately the hydrogen, however, it's very slowly, maybe 2-3 later, the kidney is going to increase the excretion of the hydrogen, plus it's going to regain the bicarbonate, so does not let to excrete the bicarbonate in the system. Now, what will happen when we do have an alkalemia? In alkalemia, when we do have less hydrogen ion, of course, now everything is shifting and relatively more hydrogen is generated from the carbonic acid because this equation is shifted toward the formation of the hydrogen and bicarbonate. So what will happen? More and more is needed. So how let's see the respiration is going to work. They want to increase the carbon dioxide level, so making more carbonic acid, so making more hydrogen. That's very important. Now, and for sure the bicarbonate is going to increase the situation, and later on what will happen? The bicarbonate excretion by the kidney is increases. So the reabsorption is inhibited and retaining the hydrogen, this kind of mechanisms that going to maintain the normal hydrogen concentration and the buffer system that release the hydrogen out of this binding. The kidney compensation. The kidney regulates the plasma bicarbonate concentration by first of all reabsorption of the filtered bicarbonate. Every day the kidney usually filters about 4 mole of bicarbonate and about 80-90, as the previous slide showed, the 85% is reabsorbed in the proximal tubule. Another one, the kidney can form acid. This is what is called using the phosphate buffer system. So this can produce hydrogen, and that can come back, so can be retained, for example. So when you generate the hydrogen, this is good, for example, to control in metabolic alkalosis. Now, the excretion of ammonia, this is how we can excrete the hydrogen. That's usually happening in the distal tubule. This ammonium is generated from the glutamine through the alpha ketoglutamate, and that going to produce 2 moles of ammonium and glucose and 2 bicarbonate as well. The bicarbonate can be reabsorbed and the ammonium is excreted. So this is how we can excrete the hydrogen ion in the kidney. So the ammonium is a primary adaptive response since ammonium production from the metabolism of the glutamine can be increased in the presence of acid load immediately. Now, acid-base disorders and the compensatory mechanisms. Now, when we are talking about an acid-base disbalance, we do have two situations, as I mentioned before. When we do have an increased hydrogen ion concentration, This is what is called acidemia. And when we do have less hydrogen, that is called alkalemia. Now, depending on which component can explain the changes of the pH, these are the primary disorders, okay? If we do have the changes in the bicarbonate, these are the metabolic disorders. For example, if we do have acidemia, and mainly we do have a decrease of the bicarbonate concentration, that's a primary metabolic acidosis. If we do have alkalemia and you do see that the bicarbonate level is elevated, that's a primary disorder. We do have a metabolic alkalosis. Now, when you have similarly acidemia and the PCO2 increases, you know that that's a primary of the respiratory acidosis. If you do have a alkalemia and you do see the carbon dioxide level is down, that is a primary respiratory alkalosis. Okay, so alkalemia and acidemia means the concentration of the hydrogen similarly to the hyperkalemia, hypokalemia. Now, another thing, whether this is a primary disorders or not, whichever component explaining the changes of the hydrogen ion concentration, that's the primary disorders. For sure, then other system, for example, when we do have a metabolic disorders, the respiration is going to compensate it. Now, if we do have a primary metabolic acidosis, for sure the compensation be a respiratory alkalosis. So relatively, we are going to decrease the PCO2 level. If we do have a primary metabolic alkalosis, what the respiration will do? Accumulate the CO2, so produces a compensatory respiratory acidosis. Now, very similarly, when we do have a primary respiratory disorders, we do have the opposite metabolic compensation. Very, very important that you cannot compensate to normal, because if you compensate to relatively to the normal value, there is no drive for compensation. So this is why we always have a little discrepancy from the normal value of the compensatory mechanism as well. Now, because you cannot compensate the normal, you cannot overcompensate or undercompensate. If we do have, this looks like we have too much, for example, CO2 or too much bicarbonate produced, that relative meaning we do have an other underlying metabolic or respiratory disorders. Now, the kidney compensate for changing of the bicarbonate, while the lung compensate for the changes of the CO2. So it meaning that the kidney is a metabolic compensation, while the lung is a respiratory compensation. Now, respiratory acidosis. So respiratory acidosis means we do have an acidemia. So the pH is decreased. Now, what does it mean? And we find that the CO2 level it increases. So if we do have an increased PCO2 level above the 45 millimercury, this is called a hypercapnia, and we do have a high level of the CO2 in the blood. Now, what will be the cause of this respiratory acidosis? That can be chronic, it's most commonly the chronic situation, and acute condition. For example, the chronic situation can be in any kind of nervous problem, the depression of the respiratory center that controls the breathing rate, for example, drug or head trauma, or paralysis of the respiratory or the chest muscle, or if somebody is suffering from the chronic obstructive pulmonary diseases. Usually it's associated with the pumping abnormality. We do have a lecture about respiration, and there you will hear the causes and the mechanism of this respiratory problem. In acute conditions, when we do have, for example, an adult respiratory distress syndrome, the ARDS, that, for example, now this is the cause of this coronavirus infection, or pulmonary edema, or pneumothorax, the all acutely is going to alter the respiration and will increase the PCO2 level suddenly. Now, let's see the metabolic balance before the onset of acidosis. Now, this is the normal situation. Now we are going to talk about the metabolic disorders. Normally, as we said, that the acidic component of the bicarbonate, such as the carbonic acid, is about 1 unit, while the bicarbonate is about 20 times more. All right. Now, and this kind of bicarbonate is associated with some other ions, such as the sodium, potassium, magnesium, and the calcium. So that's a normal situation that will happen in the pH of 7.4. Now, what will happen when we do have a respiratory acidosis? So when we do have a suppression of the breathing and we do have an increase of the carbon dioxide level in a body, so more carbon dioxide is going to produce more carbonic acid. And of course, it's going to dissociate to, let's see, proton and bicarbonate, but the ratio now is changed. As you see here, now we do have 2 units and we do have 22. So relatively, the ratio now it's a little bit increased. So this is why the pH is going to decrease. So we do have more hydrogen produced, and the pH is the negative logarithm of the hydrogen ion concentration. This is why we do have a acidemia. Now, how can we compensate this situation? Well, the kidney is going to turn on, and what the kidney does is going to withdraw or retain the bicarbonate ion to somehow to restore the normal ratio. And the normal ratio should be, the normal is 1 to 20, and in this case it should be about 2 to 40. But because we cannot restore the completely normal situation, what will happen? We do have about 2 to 30, so relatively the pH is going to elevate a little bit, so we are getting closer to the 7.4, but we are not going to reach it. As a normal situation, when we do have a normal compensation, relatively is going to bring back the pH to the lower or the higher normal value. So in this case, for example, the patient can have about 7.35 when we do have a compensation, normal compensation. Now, and the same way, the kidney is going to eliminate the hydrogen ion, and this way the urine is more acidic one. Now, if we want to restore completely the normal thing, what can we do? We can give lactate. And because the lactate is metabolized by the liver, it produces bicarbonate. Now, this is going to compensate or give back the normal ratio of the carbonic acid and the bicarbonate. But first of all, it's very important, not the hydrogen ion concentration or should be restored and maintained by different infusion, different drugs, but you have to treat the underlying problem, the underlying dysfunction. And it itself is going to compensate it. Respiratory alkalosis, relatively rare condition, mostly causes by hyperventilation, and that lead to eliminate the excessive amount of carbon dioxide and has an increased loss of the carbon dioxide from the lung if we are, for example, breathing faster than the production occurs. And what it will happen, it decreases the hydrogen ion concentration. Now, what can be the most common cause of this respiratory alkalosis?
Go! 30 seconds. Let's go. Tell me what it is.
Do it.
Put him down. You're fine. It's not going to hurt you.
Okay.
Not going to hurt you. You'll be fine. Come on. Grab and tell me what it is. Let's get this over with.
It's warm! It's warm!
It's not that bad. Pick one up and tell me what it is. Get in there. Come on. You could have been done by now. It's not gonna hurt you.
Are you sure?
You could have been done by now. Yes, I'm positive. I've done it a couple of times.
Pick it up.
There it is. Pull it out. Tell me what it is.
We need a guess, man. We need a guess.
So hysteria, that can be the most common cause when we do have hyperventilation. That's an interesting story. The hysteria and hysterectomy is closely related to each other. A long time ago, they tried to treat hysteria by removing the uterus. They believe that the ladies, when everything is rise from the uterus, and that causes, let's see, the increased rate of breathing and the hysteria. Now today's they figure out that is not exactly the cause, because the men can be hysteric as well, not only the ladies. Now, but not only the emotional disturbance can cause, let's see, hyperventilation, but if you do have a respiratory center lesion, tumor or stroke or fever is going to increase the respiratory risk. Or drugs such as the salicylate poisoning, when we overdose the salicylate, that can stimulate the breathing center directly. And this can increase, let's say, the hydrogen ion concentration, and that can cause hyperventilation very easily. Or if we do have an assisted respiration, that we're going to do more than is needed again. Or when you are going to the heel, up to the heel, and low PaO or hypoxia, that can stimulate the respiratory system and can cause hyperventilation. Now, the respiratory alkalosis, when the hyperactive breathing happening, relatively when we blows off the carbon dioxide, so what will happen? Okay, we are going to remove the carbonic acid level decreases, so the ratio now it's be less. This is why we do have an increase of the pH, because the hydrogen ion is be less. Now, what can happen? Well, the kidney is only source that can somehow regulate the system. What the kidney does, okay, because we do have relatively more bicarbonate, okay, they are going to let the bicarbonate pass through to the urine and making alkaline urine. So, and plus it's going to conserve to or resorb the proton concentration, produce and resorb the proton concentration. Now, as you see here, the ratio is getting closer to the normal, because the kidney is not able to normalize back the pH. If it's needed, we can add ammonium chloride. In ammonium chloride, the chloride is going to be exchanged by bicarbonate, and this is what is going to increase the bicarbonate loss and normalize the ratio back to the normal. Now, in a case of the metabolic acidosis meaning that we do not have enough bicarbonate. So there are two possibilities. How can we have less bicarbonate? One thing, when we do have an acid substance that's going to be buffered by bicarbonate, and this is why we lost bicarbonate. Or we are losing bicarbonate through the kidney, through the other possibility mechanism. Now, to differentiate between whether it's caused by the acid production or acid accumulation or loss of bicarbonate, we call this anion gap. Now, what the anion gap means? Anion gap is calculated that when we do have the positive charges and we are going to subtract the negative charges. Now, hypothetically, the positive and negative charges in our body should be equal. So if you could measure the all positive charges, the all cations, and measure the all anions, they should be in molar range, it should be equal. However, because we are unable to measure the all, this is why we measure only the sodium, the most abundant cation, and chloride and bicarbonate. When we do have an extra acid that is accumulated, we do have an increase of the anion gap. If we do have a normal anion gap, that's about 12 plus minus 2, we have a loss of the bicarbonate in our system. Now, let's see how this thing works with a little animation. We do have, as I said, electroneutrality. It's meaning that we are not a battery. We cannot accumulate the negative or positive charges separately. So you are not sparkling in the light. So this meaning that if you do measure the all cations and anion, that should be equal. Now, we do have zillions of cation, as you see here in a blue panel, and we do have zillions of other negatively charged anion, and they unequal. But because we are not measuring everything, we're measuring only the sodium and the chloride and the bicarbonate, and we not measuring a small amount of anion, such as the organic acid, the sulfate, albumin, phosphates, etc. So this is why this difference between the sodium and the negatively charged chloride and bicarbonate, that give you this anion gap. Now, what will happen when we do have anion gap acidosis? Let's see. When we add extra acid to the system, the proton is going to buffered by bicarbonate, bicarbonate making the carbonic acid, all right? And carbonic acid is going to dissociate it to water and carbon dioxide. Carbon dioxide is going to eliminate it, and the lost bicarbonate, the negatively charged bicarbonate, what is be less, is substituted by, for example, acetate in our case. So we do have a negative anion of the acid that is B in the system. But because we are not measuring, this is why the anion gap is going to increase. Okay? So we lost bicarbonate, and because the other ions of the acid substitute the bicarbonate, the anion gap is going to increase. In a case of a non-anion gap acidosis, the reason why we do have, let's say, acidemia, because we are going to lose the bicarbonate. However, we cannot lose negatively charged anions separately, so this is why the bicarbonate exchanged by chloride. So this way the amount of anion stays the same. However, we do have more chloride. So this kind of acidosis called hyperkalemic acidosis as well. And the anion gap did not change. Now if you look, let's see that this table. This table is going to tell you that what could be the reason why we do have metabolic acidosis. If we do have high anion gaps, when we do have a higher anion gap than 14 millimole, the first and most important one that you have to check, the ketone bodies, because very commonly the diabetic ketoacidosis is the cause of acidemia. You have to check the ketone bodies. If you do have an elevated level, you can check in the urine, for example, and that means ketoacidosis. Now, if you have normal ketone bodies, the next one, the lactate. Most commonly, the hypoxia-induced lactic acidosis is another cause. And when you measure the lactate and the lactate is higher one, now you have lactic acidosis. Now, if you do not have any of these two, or neither of these two, the next one, you should look at the osmotic gap. Why? Because you have to decide whether this is due to something that the patient was taken from outside and the metabolite or the component it caused the acidemia or not. So to fish out what the cause is, the next one is the osmotic gap. The next slide is going to show you what the osmotic gap is. Now, if the osmotic gap is less than 25 milliosmol per kilogram, that's a different story. Or if you have a higher one, that's another different story. Now, the normal anion gap, another thing, you should measure the urinary anion gap to see whether this is due to a kidney abnormality. When the anion gap, urine anion gap is increased, that's a kidney abnormality. Or if it's normal, now possible you have a GI loss or you do have some kind of wound bicarbonate loss. Now, what is the most common cause of metabolic acidosis or the acid accumulation? When we do have an increase in ion gap, usually is due to the production of endogenous acid. The DeMott-Pice mnemonic will tell you that most commonly the patient ingested methanol, or they have a kidney uremia, or diabetic ketoacidosis, paraldehyde they're taking, or infection, or NIH, they're treating tuberculosis, or lactate acidosis, or ethylene glycol, or salicylate poisoning. And in kidney, mostly the lactic acidosis and metabolic disorders or renal failure that can cause anion gap metabolic acidosis. Now, the osmolar gap, as I promised, the osmolar gap is the difference between the measured osmolarity and the calculated osmolarity. We can calculate the osmolarity because osmolarity mainly determined by the small soluble particles in the system. Now, these particles taking twice the sodium, we don't need to calculate the potassium. In some equation include the potassium as well. We are taking twice because the sodium is not alone. That's a strong acid and a strong base salt. That's a sodium chloride. So the chloride should be taken as well, but this is why you're taking twice because the same particles, twice the sodium. And glucose and urea. Now, this gives you roughly the normal osmolarity. The difference is around 12, 15 or something that's very low. Now, if you expose to the ingested alcohol, this meaning that you are taking some osmotically active particles, so the measured osmolarity, that measuring by the changes of the freezing point, so what will happen? The measured osmolarity be higher than the calculated osmolarity, so the osmotic gap is high. So this meaning that we do have some kind of low molecular weight particles in our body. Now, what will happen? When we do have an alcohol, of course, at the beginning, the alcohol is still there. So this alcohol is not metabolized to any kind of acidic compound. Acetic acid is not formed yet. However, as the metabolism is going on, more and more acetic acid is formed, and this is why the anion gap starts to increase. And as long as we do have this conversion, the alcohol is disappearing from the system. Why? The acidic substance is accumulating in the system. So this is why these two line is usually is crossing each other. So and the osmotic gap is higher than 25 milliosmol per kilogram. Now another thing, when the differential, how can we use this osmotic gap to differentiate the cause? If you do have less osmotic gap, mostly this is due to uremic acidosis, lactic acidosis, ketoacidosis, and salicylate. But I could say that mostly the internal causes. However, when you do have a very highly increased osmotic gap, this is the external sources, ethylene glycol that is usually is metabolized to oxalic acid. So in the urine, for example, you can find oxalate crystals, or in methanol intoxication, you should use, for example, the checking the visual changes. The best thing to use, for example, the antidote for these two is ethanol. Ethanol is less toxic than these two components. Now, lactic acidosis. Lactic acidosis, there are two different part of this lactic acidosis. Hyperlactemia, usually meaning that we do have an elevated lactate level. However, this not influences the pH. So the normal lactate levels in the critical patient relatively is less than 2 millimole per liter. The minor elevation that very well correlated with the mortality of the patient in the intensive care unit or with the sepsis. So that's alone the lactate level is very, very important, for example, to estimate the survival rate of the patient or the metabolic situation in the patient. Now, when we do have a very highly elevated lactate together with the acidemia, that is called the lactic acidosis. There are two types, A and B type. The A type, we do have an overproduction of lactic acids, mostly due to anaerobic glycolysis that happening in hypoxia, for example, shock, hypoxemia, anemia, or carbon monoxide poisoning. And you should consider that the body can generate, in the situation, can generate about 12 millimole per minute lactic acid. So that's a huge amount of lactate that the body is going to produce. Now, the B type of the lactic acidosis is not due to overproduction, but this is due to the decreased liver utilization. That is most commonly a congenital defect in the glucose and the lactate metabolism. That's a genetic mitochondrial diseases, but some drugs and vitamin deficiencies a toxin can cause it. It's much less common than type A acidosis, so it is not as severe and much easier to treat it comparing to the type A. The non-anion gap metabolic acidosis, when we do have, for example, a retention of the hydrochloric acid, or we do have a loss of bicarbonate in proportional to the excess of the chloride. This is what we meant, that's the hyperkalemic acidosis. Now, the most common cause of this normal anion gap acidosis, this is called a hard up. When we do have an endocrine disorder such as a hypoaldosteronism or hyperosmotic non-ketoacidotic coma or acetazolamide, there's a carbohydrate inhibitor, for example, renal tubular acidosis, diarrhea, uretrosigmoidoscopy, ileostomy, or pancreatic fistula that all can cause non-anion gap acidosis. Now, how can we use urinary anion gap? Urinary anion gap will tell us whether the cause of the non-anion gap acidosis is due to the renal problem or an extrarenal problem. The extrarenal problem means that the kidney works perfectly, so the kidney can eliminate the extra acid. Now, what will happen? Let's see how we calculate urinary anion gap. Very similarly to the serum anion gap, the neutrality, electroneutrality has to be here as well. So the all positive cations and the anions should be, negative anions should be the same. We cannot measure the all, but the most common one is sodium and potassium, and the anion is the chloride. So making the difference between these two. Now, what will happen when we do have a normal kidney function, when we have an extrarenal cause of non-anion gap acidosis, such as the GI loss, for example, or such as, for example, the wound fistula or anything. Now, in this case, what's happening? Because the kidney, the distal tubule, is going to produce more and more ammonium. This meaning that is going to increase the positive charges. Again, we cannot have more positive charges than negative, but the kidney will increase the chloride concentration as well. So, but because we are not measuring the ammonium, and the chloride be higher one, and the sodium and potassium stays the same, the urinary anion gap be less than -10. However, when we do have a kidney problem, what's happening? The kidney is unable to excrete the ammonium. So what will happen? The chloride level is be much less than the sodium or potassium. So in this case, the urinary anion gap be higher than +10. And usually this is the cause is a renal tubular acidosis with the distal acidification defect. Now, the renal tubular acidosis, the metabolic acidosis, when it's due to the defect of ability of the kidney tubules to perform their function. This form of metabolic acidosis usually results from either retention of the hydrogen chloride or hydrochloride or the net loss of the sodium bicarbonate. Now, all forms of renal tubular acidosis characterized with a normal anion gap, or it's called hyperkalemic metabolic acidosis. The major cause of normal anion gap acidosis in the patient without renal failure, this is what he said, that's a diarrhea. This is you should keep in your mind. Now, let's see the type 2. Let's start with type 2. The mechanism is isolated bicarbonate reabsorption defect in the proximal tubule. That can be inherited defect of the sodium bicarbonate co-transfer, the NBC1, that's an autosomal recessively hereditary disorders, and with concurrent ocular abnormalities. The mutation of the sodium proton exchange, the NHE3 autosomal dominant diseases, or the defective carbohydrate activity. So this is the most common cause of this renal tubular acidosis type 2. Now, the isolated defect relatively very rare. Most patients have multiple defects in the proximal tubular function, and usually this is the Fanconi syndrome together with Fanconi syndrome. The most common cause are multiple myeloma, and that's a required one, and using a carbohydrase inhibitors, for example, that the acetosamide. In children, in cystic fibrosis is the most common cause of the renal tubular acidosis type 2. Now, what will happen? The metabolic acidosis that decreases the net reabsorption, the proximal tubular reabsorption of the sodium, that leading to the increased tubular delivery of the sodium, which promote the potassium secretion. The proximal renal tubular acidosis leads to salt wasting, volume depletion, and secondary hyperaldosteronism. The rate of kaliuresis, the potassium excretion, is proportional to the distal bicarbonate delivery. Alkaline therapy can aggravate the hypokalemia. So when you give more bicarbonate solution, that meaning that it causes hypokalemia. Now, the proximal renal tubular acidosis is a self-limiting disorder, usually, where the serum bicarbonate is higher than 12, as the distal acidification mechanism are intact. And the urine pH usually is less than 5.5, but became alkaline when bicarbonate losses are corrected. And you can see that how the kidney is losing bicarbonate. Now, type 1, the distal tubular renal acidosis, that's a classical type. It's associated with a defect in the distal hydrogen ion excretion. The mechanism is the decreased proton pump in the hydrogen ATPase activity, and this is the hypokalemic distal renal tubular acidosis. Now, another thing, when we do have an increased luminal membrane permeability with breaking the hydrogen ions, such as, for example, the amphotericin is an antifungal agent that making pores on the tubules, and that is another type that is called a hypokalemic distal renal tubular acidosis. Another thing that can happen, for example, when we do have a diminished distal tubular sodium reabsorption, which reduce the electrical gradient for the proton secretion, and in this case we do have hyperkalemic distal renal tubular acidosis. So by measuring the serum potassium concentration, we can figure out roughly what the mechanism could be. Now, what can cause the distal renal tubular acidosis? In children, primary, idiopathic or sporadic, or autosomal dominant recessively or recessively transmitted diseases. In adult one, mostly the Sjögren's syndrome, rheumatoid arthritis, that's autoimmune disorder, SLE, hyperglobulinemia, obstructive uropathy, for it may be hyperkalemic as well, for sickle cell anemia, and that can be hyperkalemic as well, or hypercalciuria. Some drugs and other is a less common one, but these are the very common disorders as listed in the, let's see, in the different colors. Now, the type 1 renal tubular acidosis, the distal one, if you look at the lab value, usually the urine pH is higher than 5.5. And the serum bicarbonate is less than 12, so it's a more severe metabolic acidosis. Positive urinary anion gap, the excretion of ammonium is low as the result of less ammonium trapping. It is often associated with hypercalciuria or hypocytraturia or nephrocalcinosis and osteomalacia. That's very, very important. The type 4 renal tubular acidosis, this is a hyperaldosteronism induced situations. The major cause of hypoaldosteronism, the aldosterone deficiency, as we learned primary adrenal insufficiency or congenital adrenal hyperplasia, particularly when we do have a 25-hydroxylase deficiency, and heparin and isolated aldosterone synthase deficiency, it's very, very rare. Or aldosterone resistance, when we do have, for example, renal disease that the aldosterone cannot effect on the kidney, or volume expansion, as in an acute glomerulonephritis, or angiotensin-converting enzyme inhibitors, or NSAIDs can cause it. Cyclosporin, some other causes of the obstructive uropathy can cause this type 4 renal tubular acidosis. Now, the differentiation or differentiating between the type 1 and type 4. In type 4 renal tubular acidosis, hypoaldosteronism leads to the rise in the plasma potassium concentration. Why? When you do have a type 1 renal tubular acidosis, the aldosterone levels usually is normal, and the acidifying defect is more severe one. So the urine pH is more than 5.3, or the plasma bicarbonate level is relatively very low one. While in 4, we do have a lower urine pH. That's good because we can excrete a proton, and the bicarbonate usually is higher as comparing to the type 1 renal tubular acidosis. Now, what about the type 3 renal tubular acidosis? It's very, very rare. That's a mixed distal and proximal renal tubular acidosis. That's a genetic defect in the type 2 carbonic anhydrase found in the both proximal and distal tubular cells and the bone, and osteoporosis, cerebral calcification, mental retardation can be an additional side beside of this tubular acidosis. Now, so far what we discussed, that was the long and an old version of the acid-base disorders. However, there are some new concept of the acid-base balance, expressing the acid-base balance, because the Sigar-Anderson or the Hasselblad equation, it's very good to explain the normal situation. However, when the patient is sick and we do have a very weak capability to accommodate or to that's relatively the metabolic functions are very bad. Now this acid-base equation does not work. This is why the stewards develop an other acid-base theory. Now let's see what is the acid. So far we said that acid is everything that relatively is going to increase the proton concentration in the solution. However, not every proton donor is acid. For example, ammonium. Ammonium is more alkalic one. Lactate, another thing. The lactate is not an acid, and is no proton is getting out from the intracellular space to the extracellular space. So the lactate is immediate, or the lactate is released out. However, the proton stays intracellularly and used up for the ATP synthesis. So we do not have a proton that's coming out. We do have only the lactate is coming out, a negatively charged ion, and that can cause acidosis. Why? It's strange. Now another thing, it's a unanswered observation, and usually in the intensive care unit, the doctors already figured out this one a long time ago. Now let's see the administration of the sodium chloride on the pH. Let's have 5 liters of water and 5 liters of plasma. What will happen? And the pH is 7.4. What will happen if you infuse, or we add 1 liter of sodium chloride to 5 liters of water, or we giving 7.4 pH saline to the 5 liter of plasma? Now let's see what will happen. In the case of the water, the pH doesn't change. Everything stays the same, except, as you see here, that the volume is increased. But what will happen when we do give the saline to the plasma? Well, the pH is going to decrease. So they are going to develop a hyperkalemic acidosis. And this is what they already figured out when they infuse the patient, a very sick patient, with sodium chloride. Usually the acidemia be more severe one. So this is why the saline can increase the hydrogen ion concentration. But how and why? Now another thing, the water. You know very well that the water is going to change its pH. When you measure the water pH, for example, at 0 centigrade, that's about 7.5. At 25 centigrade, of course, the dissociation of the hydrogen and hydroxide the same, so the pH is about 7. However, if you start to warm up the water, the pH is going to decrease. So is the water is acidic? Well, and why the pH is changing? Because the association or dissociation of the water molecules is different one. Relatively the least that we can find the proton and hydroxyl ion alone, mostly we have hydroxyonium and different association with hydrogen and oxygen. And if you see that the relation between the quantity of the water electrolyte in the body, let's see, the plasma volume. Okay, the plasma volume that has water, electrolyte, and let's say hydrogen. Let's see, one molecule is hydrogen and the electrolyte about how many? 3 millions more. And wow, the water molecules and the hydrogen and water molecules is much, much, much higher. Why is it important? Well, this is why Stewart they developed this a new model. This is called the Stewart acid-base model, and this works very well, especially when the patient is very really sick. Now, the acids increase the amount of hydrogen in the solution. The added or removed hydrogen affect the solution's hydrogen ion concentration indirectly. The hydrogen ion is not an independent variable. This is what he says. Now, what we do have in a plasma? We do have a strong ions that is completely dissociated at the pH what we have, such as, for example, the sodium, potassium, chloride, lactate, magnesium, sulfate, that's one. Now, they do have, let's see, a weaker dissociating ions when the Kd value is close to 6.8, such as albumin or phosphate. And another, the buffers dependent on the respiration, so this respiratory portion, the carbonates. Now the buffers independent from the respiration has to be considered as well. Now the weak acids at the plasma should be considered as a pseudoprotonated acid. The strong ions are capable to cross the membrane and influence the extracellular hydrogen ion concentration. This is what he. Now let's look at the effect of saline on the proton concentration. Now, what is the difference? When you give saline, the saline has more chloride in it. So this is why if you infuse the more chloride, then we do have in a plasma. So because the normal plasma chloride around 100 millimole per liter, and we give 144 millimole per liter. So we do have extra chloride in the plasma, and so we increase the negative charges. So what will happen? We cannot have a separately increased negative charges. This is why the water dissociation is changing and more protonated form can be found. So this is why the hydrogen ion concentration is going to increase and the patient will have acidemia. Now, this is what they figured out very early. It's in the very early 19s, for example, 1934, they gave a report, published a paper. When they infuse Ringer lactate solution or saline, they figured out that the patient, the children, can recover much faster from this situation when when they give lactate comparing to only the saline solution. So this is the answer, because in a situation where the patient is suffering of hypoxia, relatively the saline is worsening the metabolic acidosis. Thank you very much. And now the Kahoot is coming up. Prepare your cell phone, and we are starting right now. Thank you very much.